I'm going to start with some work that my PhD student did some 10, 15 years ago now. And this is the global data on diabetes. And you want to ask the question, when you have diabetes, how much and what does it do to cardiovascular outcomes? So if you look at coronary disease outcomes, it exactly doubles your risk of coronary disease. You sometimes see these references to 2, 4, 8-fold. But if you look at 25,000 events from 500,000 people, you basically see a doubling. Now the issue with this is that this is fatal and non-fatal events. And what you'll see below that, the first presentation is often with a first fatal event. So actually prevention of diabetes becomes really important, because often you make the diagnosis after a cardiovascular event and then you're playing catch up. If you look at cerebrovascular diseases, unlike, for example, LDL cholesterol, not only does diabetes increase the risk of ischemic cerebrovascular events, but also hemorrhagic cerebrovascular events, similar to the way that hypertension does, but also increases risk at the bottom of other forms of vascular death. Now, you can look at relative terms, but you can also look at life years lost, and that's become increasingly important. On the left-hand side, you can see the current global prevalence of diabetes, and then you, on the right-hand side, based on current global prevalence, the proportion, attributable fraction of deaths around the world related to diabetes. So as we move from 11% prevalence to 30% prevalence and 40% prevalence, 1 in 5 deaths that occurs may be due to diabetes. So prevention, as we'll see later on this morning, of cardiometabolic traits really becomes very important on a global scale when you have 8 billion people. On the right-hand side, we can basically get an idea about what we need to do at different ages at which diagnosis is made. So if you are diagnosed with diabetes aged 40, whether you're a man or a woman, you lose half a decade of life. Half of those life years lost are going to be from cardiovascular diseases. But even though the relative risk in somebody, for example, with diabetes diagnosed later in life is going to be a twofold increase or a doubling, you basically have now fewer life years to gain. So basically in that situation, you might adopt a different approach in older versus younger individuals. So the thinking about diabetes from a therapeutic point of view is we make the diagnosis by basically looking at glucose levels or HbA1c. So that must be the bad guy, and therefore changing that must improve outcomes. So this is, if you like, mediation, sequential adjustment, looking at how much of the risk results from other conventional risk factors that often cluster with diabetes. And if you basically take into account most of the conventional risk factors, there is some attenuation, but the vast majority of risk is unexplained. So again, prevention becomes very important, but this led to intervention trials with glucose-lowering therapies. Now, these were mostly insulin and sulfonylurea based. And if you look at the totality of the world data, and you look at a 1%, 0.9% reduction in HbA1c over about 5 years, what you can see is there is a reduction in the risk of the combination of fatal and non-fatal MIs, driven mostly by fatal MIs. But there are a lot of other outcomes that start to look potentially a little bit worse. So a lot of these agents perhaps were not the cleanest in terms of reducing the risk of cardiovascular disease. And indeed, if you compare in absolute terms the impact of HbA1c lowering from blood pressure or LDL lowering in diabetes, you're preventing in absolute terms far fewer events. So this is largely why a decade ago we were focusing on LDL lowering and blood pressure lowering, and essentially the glucose lowering was more for microvascular disease. But that did allow us to do certain things, look at new treatments, and so the first next set of treatments that were being tested were the DPP-4 inhibitors. And again, if you pull the first set of studies, 35,000 or so individuals, now an HbA1c of 0.4%, not 1% roughly, there is no difference in cardiovascular outcomes whatsoever. So it's great if you need that additional HbA1c reduction, but it's not protecting against end organ damage. But then as a result of testing these drugs for safety, we have seen two classes emerge. On the left-hand side, the SGLT2 inhibitors. On the right-hand side, GLP-1 agonists. And these were all essentially studying in their primary endpoint, 3-point MACE, CV death, non-fatal MI, and you can see broadly we've got two classes that have now emerged that are cardioprotective, but there are some differences between them, notably in terms of the longer-acting GLP-1s tend to give greater protection than the, if you like, the Xandin-based therapies, but also we find that with the SGLT2s, the reduction in hospitalization for heart failure, CV death, and hospitalization for heart failure, and protecting against ongoing kidney damage, which is one of the commonest reasons for dialysis around the world. So we've got even more data now, and we've clearly got two classes where in those trials that I was showing you, by design, the HbA1c changes were not 1, 1.5%, 2%. They were about 0.3, 0.4%. But yet, the benefit that you see in terms of cardiovascular disease is disproportionate to that. So what is now very clear is it matters how you lower glucose. So instead of these older approaches which were largely sulfonylurea, etc., based and thinking about insulin, for example, we should probably think about those being used only in those situations where glycemia is really poorly controlled, rather than targeting people earlier on and trying to save lives, reducing the major complications. So as an example, if you've got very high cardiovascular risk, and this is an ESC-EASD statement, and that doesn't have to be necessarily secondary prevention patients, but also people, for example, with microvascular disease with a higher event rate, additional risk factors, long duration of diabetes, that before even going to metformin, you can go down the route of thinking about, on the left-hand side, a GLP-1 agonist or an SGLT2 inhibitor, and then after that, you're then looking at HbA1c control. So HbA1c control is not the first thing that you should be looking at. You should be looking at ways to try and protect this person who is at risk of cardiovascular disease. We've got similar guidelines now, and the question always becomes, well, how do I distinguish? Well, given the clear benefits of SGLT2s on the kidney and in heart failure, and indeed in people without diabetes, further supporting the notion that these drugs work through clinically benefits largely independent of glycemic control, those patients are relatively easy to identify, and they're on the right-hand side. But on the left-hand side, you can see it's a little bit harder, and there's probably a bit more clinical equipoise between SGLT2s and GLP-1s. But the notion is the same. We should be using these treatments much, much earlier to help prolong life and reduce the major consequences of diabetes. So in conclusion, if you get diabetes aged 40, you lose half a decade of life. If you have cardiovascular disease and diabetes, it's a decade and a half. We've seen some mortality trend reductions in diabetes, but people with diabetes have a much higher absolute risk. And the interventions, in addition to blood pressure lowering and lipid lowering, we should be thinking about treatments that are not glucose-centric, but are actually aimed at protecting against the cardiovascular consequences. And with that, I'd like to conclude. Thank you.